the cycle without touching the beautiful MPUMALANGA. Let me also acknowledge the presence of our national coordinating structure, which is SANAC, in our midst. The PCA are actually a provincial SANAC. And at the provincial level, we also have a district. And then from the district, we go up to the sub until we reach the ward level. And colleagues, I think it is very, very important for me to indicate, because it looks like there's still confusion in terms of the 3-1 principle. We are a coordinating structure, not an implementing partner or implementing agent, but we are responsible for coordinating a multi-sectoral response, guided by our footprint or roadmap, which is the National Strategic Plan, using our M&E framework to monitor progress in terms of our response. It is within that context that we, as a country, are compliant at all levels, be it at the level of SANAC where the NSP is actually implemented, at the level of the PCA where the provincial implementation plan is actually implemented, developed and implemented, at the level of a district where the MDIP, the multi-sectoral district implementation plan, is developed and implemented, and at the local level where the multi-sectoral local implementation plan is developed and implemented. It is therefore within that context that we sitting here as soldiers, as foot soldiers, who are coordinating and monitoring the multi-sectoral response. They always say it is not how big is the lion in the fight, but it is how big is the fight in the lion. We might not be physically huge to be seen and be recognized and be respected as coordinating structure, but yes, indeed, we are actually a coordinating structure. Ladies and gentlemen, without any waste of time, let me call upon my co-chair, who is Dr. Litlo Onono. Makula. Pronounce Mswati. Thank you very much. Over to you, Doc.
No, thank you so much. Maybe you can just remain, Mr. Ngosi, and just also welcome the colleagues that are joining us online. I believe even colleagues from MPUMALANGA that could not attend in person are online to really hear the findings, or that will be joining us online soon. And then also colleagues from the media that are joining us or who will be joining us, just to also thank them for their presence. So as Mr. Ngosi has already mentioned, we want to make sure that we stick to the time where we are able to do so. So we should be able to finish the activities for the day by 2:30, but would like us to go through the program just to see what we have put or packaged to help guide what we need to do today. After that, just to also encourage while we are sorting out or displaying the program, just some of you that have scanned the code that is on your table and are responding to questions, please finalize responding to those 3 nice questions so that we can also just quickly go through some of your responses before we continue with some of the activities on the program. So, we plan, we've already are on the introductions, and then we are going to ask our colleagues from the Center for Disease Control and Prevention to also address us as our partner. That will be done by Dr. Heltha Pauline, who's the Care and Treatment Branch Chief. That would be followed by the team from HSRC and CDC that is led by Professor Kangalani Zuma to then share the provincial and district results from MPUMALANGA. And then we would allow you to engage the HSRC facilitators in each table. There are also questions that are meant to guide the discussions that would unfold. So we have about 45 minutes to an hour to just engage so that we have an understanding of what are the implications in terms of what is happening in the province, what are some of the issues that as a province are dealing with related to HIV as well, and certain groups that we also work with. We will have a very short tea break. We would like it to be a working tea break so that we don't spend a lot of time outside. Afterwards, we are going to allow each table to provide feedback, just a summary of what the discussions, that transpired in each table. So you will need to choose a representative that can just give a good summary. And obviously they will not repeat what has been said by other groups for the sake of time. Afterwards, we are also going to call the province to also just briefly just give a reflection on some of the discussions that have happened today, and also with regard to the presentation that would have been done by the HSRC and CDC team. We would also give you an opportunity to also reflect on the day through the evaluation form. We would show you a code just for you to respond to some of the questions. We're hoping that this is not the first and the last time that we see each other, that every time that we do this survey, would be able to also strengthen how we engage with you. So it would be helpful that you give us feedback on what you liked and what we can improve in terms of how we and the province planned to have the activities for the day. We will just have lunch and continue discussing some of the issues that were aha moments for us as we also plan to depart. So we hope that this would happen before 2:30 as indicated on the program. So just before we go into the first address by Dr. Heather Pauline, I would like us to look at the 3 questions that you responded to from the Mentimeter. If we can just have just a display of those responses. The first question, looking at your expectation for the day, just to see what, yes, the one that was online, what your responses were to that. And then the second question would have asked you about your reflection on the gallery, and would like to thank Dr. Sahir Parker and the colleagues from SANAC who prepared that gallery for us, just to reflect on our journey as South Africa in terms of HIV. So in terms of, and I'm going to ask Mr. Nkosi to just read the responses to the questions that you have. Obviously, you'll continue to respond throughout the day as some of the colleagues are just joining us. But in terms of the first question relating to the expectation of today's event, we already received about 16 responses, and Mr. Nkosi can just speak to those.
No, thank you very much, Coach. I'm not so sure whether everybody has a smartphone, because the number does not actually tally. The responses do not tally with the number of people in the conference room, unless other people have not completed the questions. If you've got a challenge of using that other phone, we would actually pardon you. But anyway, let me, in the interest of time, try to read. What are your expectations for the days for the SABSSM event? 16 responses were received. No more about the finding, HIV challenges, and I think incidents. feedback on key findings, more information, empowered, key findings on HIV, knowledge and info on to get update on stats, depth and understanding, latest development and results, to know the findings of the HIV prevalence, to learn, and the last one is performance. Can we move maybe to the second question?
Okay, so the second question was about the images that colleagues had to look at. So we seem to have fewer more responses on this one than the expectation. So maybe we can just respond to that.
Remembering the, okay, 21 responses were received. Motivational and hopeful. It looked interesting that we have come along where history of HIV pandemic, emotional, overwhelmed, calm, connected, inviting and informative, impressive, moved, thought-provoking, powerful, very positive, remembering the activist, nostalgia, excited, rejuvenated, and grateful. Let's then move to the third one, third and the final one. The number is 22 responses that have been received. Always willing to learn, persistence. I'm able to express how I feel. Things ahead, humble, I'm passionate, my character, self-love, eager to learn more, caring. I don't know what is it that the person has, but if you need anything, these people have. Goal-getter, social person, hardworking. I don't talk much, I do. I think that was supposed to be honesty or honesty. To work impact positively. I think that's about all. Thank you very much, colleagues, for the responses received.
No, thank you so much. And we will discuss in our small tables what some of these responses mean, of course. So we would like to call upon Dr. Heather Pauline from CDC Care and Treatment Branch Chief to address us before we go into the HSRC findings. Thanks.
Colleagues, as she comes, please be directed to the table that is allocated to you. Even if you feel like my friend is seated on another table, please don't be tempted. Move straight to the table where you are, and you will find your name tag there. Thank you.
Hi, good morning. Oh, that was quiet. Good morning. Thank you for giving me this opportunity to be up here. My name is Dr. Heather Pauline. I am the Care and Treatment Branch Chief from the CDC South Africa office, and just here to say how happy we are to be able to review the results of the South Africa HIV prevalence, incidence, and behavior study, or SABSSM, done in MPUMALANGA. We welcome and thank all of our colleagues here from the Department of Health, Department of Social Development, Department of Education, SANAC, and the Provincial AIDS Council of MPUMALANGA. The many and diverse representatives from civil society, thank you for being here. Our other PEPFAR colleagues, and ladies and gentlemen, all protocol observed. So a few points that I'd like to make is first a note of congratulations to HSRC, the partners and the government of South Africa for completing the 6th National HIV Household Survey and for an impressive legacy of leading the national HIV surveys in South Africa over the last 20 years. SABSSM is a survey led by South African scientists to improve the lives of South Africans. As such, SABSSM demonstrates how investment in key partners and institutions has established a legacy of country-owned data, infrastructure, and capacity to respond to current and future health threats. At the CDC in South Africa, we're really proud to have collaborated with the Human Sciences Research Council, HSRC, on this really important survey. And CDC has been partnering with HSRC since 2005 to conduct the SABSSM work through financial and technical support. And this collaboration over 20 years has been made possible by funding from PEPFAR, which stands for the US President's Emergency Plan for AIDS Relief. So today's dialogue is really just the beginning of a conversation with the Department of Health and partners about using SABSSM data to inform program strategies and planning in MPUMALANGA into the future. As with previous rounds of the survey, the SABSSM team has made granular data available to guide programming for HIV care and treatment, prevention interventions, including key data for modeled HIV estimates at the national, provincial, and district level. So really important data that feeds a bunch of models that we need. The findings at the national level are encouraging and demonstrate how South Africa's HIV policies and programs have contributed to a stabilizing HIV epidemic, increasing levels of population viral load suppression, and promising trends in HIV prevalence and incidence among adolescent girls and young women. This survey has also helped us to understand where we have made greatest progress and in which areas we need to focus on in the future. And with these data, we can strengthen our programs on HIV prevention, including testing, especially for men and youth. So as we discuss the results of SABSSM 6 from MPUMALANGA today and their implications for the HIV response, we have to remember the very different context we are in compared to when the survey was first conducted about 20 years ago. This was a time when treatment was not easily accessed and where there was more despair than hope. And I know many of you remember those days. But we now have highly effective treatment that is widely and freely available. And this treatment not only preserves lives, health, families, and communities. We now know that ART prevents onward transmission of the virus. This is the foundation of U equals U, or undetectable equals untransmittable. A person on ART with undetectable viral load has zero risk of transmitting HIV to their sexual partner, zero risk. The Minister of Health this year launched U equals U nationally, and PEPFAR looks forward to collaboratively supporting the dissemination of this important message here in MPUMALANGA. And U equals U is not only an important message to address stigma and self-stigma, and research conducted in South Africa has shown that U equals U has a positive impact on our public health priorities, leading to significant improvement in HIV testing uptake, retention in ART, and importantly, viral load suppression. So we need to focus efforts on those who do not know their HIV status, those who are still not on treatment, and those who are not virally suppressed. These are the drivers of new infections. And those who are on treatment and virally suppressed should be loudly celebrated. Loudly celebrated, not stigmatized. And finally, the SABSSM data allows us to target our efforts towards finding and linking people in need of treatment and prevention services. And by focusing the lens of provincial and district level data, today's dialogue really sets the stage for continued discussions within MPUMALANGA about how the data can inform HIV program and strategies to best meet the needs of communities. So finally, I must acknowledge and thank more than the 7,000 residents of MPUMALANGA in the province who contributed to SABSSM 6 by opening their doors to HSRC teams in participating in this study. Thank you so much.
Thank you so much. Heather, so we're just going to try and move the table a bit to allow colleagues that are going to present.
I can't see.
So, okay, no, thanks. I think it is much better now. So, we're just going to allow the colleagues from the HSRC and CDC to present key findings for the 6th South African National HIV Prevalence, Incidence and Behavior Survey for MPUMALANGA. They will be led by Professor Kangalani Zuma, who will then call upon the other research teams that will also share the results with us. Please, warm welcome to him and the team.
Okay. Morning, colleagues. And thank you very much, program directors, and thank you, colleagues, for joining us. Whilst we're waiting for a presentation to show on the Zoom, I think today I can take this opportunity and remind my colleagues that yes, we're in MPUMALANGA, not MPUMALANGA. So I'm sure they will remember that, because they laughed at me the other time when I said in the province of Limpopo, and I was told that it's not Limpopo. Okay, colleagues, we can start the presentation. Colleagues, I will be taking you through the presentation of a study, the HIV Prevalence Survey, as my colleagues have indicated. This is the study that is implemented by HSRC together with its partners, as my colleague from CDC, Heather, has indicated. And this is the study that has been conducted at HSRC since 2002, when we implemented the first study. Now, the first study was actually pioneered by our former president, Dr. Mandela. And this is the study that has been used by the country to actually provide information about where we are with the HIV epidemic. Now, in the presentation, I will take you through, as indicated, the background, as I've already given part of the background. I will take you through the objectives of the study, which one of them is that the study is used actually to provide information to our national strategic plan, which is the study itself is a major source of information for our national strategic plan on HIV, STIs, and TB. Now, colleagues, as indicated, this is a study that has been there for so many years, and we continue implementing the study together with our partners, and the study has been actually expanding. Every time we implement this survey, there's something new that is implemented in this study. So we expand in scope. For example, when we started the study, we were getting to households and we're inviting people to participate. Only a sample of people were invited to participate in the study, and they participated in the study. We used to take at most 4 people that were invited to participate in the study in different age groups. So we have increased the sample size. These days, when we get to a household, we invite everybody to participate in the study. And we have also increased the sample size in the sense that we no longer only provide results at national level or provincial level, but we actually even now are able to provide results at district level in some of the districts that have been sampled to participate. So we're able to provide results down at the level of a district. So as indicated, as part of expansion, we now take everyone in the household to participate in the study. Also, colleagues, who have increased the biomarkers. These are the samples that we take. We have increased the number of specimens that we take so that we provide relevant information about HIV epidemic at the time that we need that information. Now, how is this study designed? Sorry, before we get to the study, what are the key objectives of the study? One of them is to estimate HIV prevalence at national level, at provincial level, as well as at district level. Now, we know we've got so many districts in the country and would want to get to all the districts, but due to constraints, financial constraints, only a sample of districts could actually be sampled where we are able to provide detailed results at that level, and that information will be made available today. Now, we provide information about HIV prevalence at these levels among adults and children. We provide information about exposure to antiretroviral treatment, so we're able to present results about the proportions of people who are on ARVs, provide information about viral load suppression among those that are living with HIV. And we also estimate at national level HIV incidence. So this is the proportion of people that seroconvert. Say, for example, at the beginning of the year, if we've got so many people that are HIV negative, by the end of the year, you take a calculation of how many people actually have become HIV positive during the course of the year. So that provides us with the HIV incidence. Now, we are only able to provide this information at national level and not at provincial level or by other subcategories. And the reason being, for one to be able to properly compute these statistics, you will need to have so much sample size, you need to have so many people that would have seroconverted so that you are able to provide these statistics at granular levels. And of course, with the current situation where the incidence has gone down, we do not have as many people to be able to compute at other granular levels. So which is, in quote, a good thing because it means people are not getting infected with HIV. But obviously for those that are statisticians interested in numbers, it's not good news for them because they don't have sufficient numbers to be able to do those calculations. So the incidence will not be able to provide at a lower level than the national level. Okay. So how is this study designed? The study is stratified at national level by province and also by geotype. So what does this mean? So before we go to the field, collect information, we have in the country, each area in the country belongs to what you call a small area layer. So the small area layers, it's a database that is housed by Statistics South Africa. Small area layers are small geographic communities of about 250 to 300 or so household or visiting points in each of these geographical areas. There are about 84,000 or so of these small area layers in the country. Now what we do at HSRC, the statisticians involved in the process, they will take a random sample of over 2,000 of these small area layers. And now they take sufficient numbers of these small area layers in each of the 9 provinces. So that is the strata. And also we take sufficient small area layers at different districts. There are 33 districts that have been identified or selected to be part of the study so that we are able to provide information at the lowest level. 27 of these districts are districts that have been identified as PEPFAR priority districts. So these are districts where there are PEPFAR activities there. 6 of them were identified as priority districts by National Department of Health. So in the province of MPUMALANGA, for example, Ehlanzeni, Kharsibanda, and Kangala, the districts that are involved in the study. So hopefully going forward, one day we'll be able to do all the districts in the country so that we've got enough information at different districts about HIV epidemic. So once the small area layers have been randomly selected, now within each small area layer, we then randomly select 15 visiting points. So that's the second level of sampling. Now within the sampled visiting point, Our GIS colleagues, they will print maps with the dot indicating exactly which household that is supposed to be visited. Within the selected household, then we invite everyone in that household to participate in the study. So that's why we said it's a take-all approach. So there are multi-level stages of sampling that we use. So that is why the study is called, it's a multi-stage household survey. It is cross-sectional in the sense that we go to the household, we invite a person to participate. Now this is the study, or the design is called the second generation surveillance survey, because once a person has been invited to participate, completes a questionnaire, then the next step is to invite that person to provide a blood specimen. And we link the questionnaires and blood specimen together so that we are able to analyze the questionnaire information together with the specimen. So that is why these are called the second generation surveillance surveys. And these are studies, or the design has been recommended for these surveys, and it has been implemented for a number of surveys in the country and also by other countries, whereby the HSRC team involved in these studies has actually provided technical support in other countries on implementing these studies. So the survey was implemented during the period from January 2022 up to April 2023. So that's why we call the survey SABSSM 2022, because the majority of the data was collected during year 2022. So in the province of MPUMALANGA, we expected, when we did our sample size estimation, we expected a sample size of just over 9,000 people to participate in the survey. Now, each red dot there indicates actually the small area layer. So each dot there would actually be a community or a geographical area of about 250 to 300 or so households. So you can see how these dots were distributed over the province of MPUMALANGA. Now, once we get to a household and we've been allowed to conduct the survey, we administer a questionnaire which we call a household questionnaire. Now, this is the questionnaire that collects information at household level. We collect information about the household situation, and we take also a listing of members of the household. So this is a household census questionnaire. The next questionnaire that we administer is, if there is a child that is younger than 12 years, then we administer a questionnaire we call it a parent or a guardian questionnaire, whereby the parent or guardian responds to a questionnaire on behalf of the child. And then when it comes to collecting a specimen, obviously, we collect the specimen from the identified child. The next questionnaire that we administer is a 12 to 14-year questionnaire. That is the questionnaire that is a children questionnaire administered among those children that are aged 12 to 14 years. So in that questionnaire, we do have some basic questions about sexual behavior also. But the more detailed questionnaire, which is the CAP survey of the CAP part of this survey, is the 15 years and above. That's the adult questionnaire, where we ask a lot of detailed questionnaire about HIV epidemic, knowledge, attitude, perception, as well as behavior. Now, as indicated, that once a questionnaire collection has been completed, people are then invited to complete or to provide a blood specimen. Now, we use a dry blood spot to collect specimen, and we do a finger prick, collect blood, and then we do spotting on the Kutri card there so that that could go to the lab. But for children that are younger than 2 years, we then do a heel prick among the young ones as a way or as a method of collecting blood specimen. And you will see, colleagues, that one of the challenges is that of encouraging people to participate in these surveys. And again, as we are here, I hope that when we prepare and go back to the field, hopefully sometime soon to prepare for the next survey, we'll be able to work together or find ways or discuss ways of encouraging people to participate in these surveys, because without their participation, then these studies will not be a success. So we do need to work together to encourage people to participate, especially when it comes to specimen collection, because that is where the challenges are. Now, this is a flow diagram of how testing is done. Once people agree to provide a blood specimen, then we take the blood specimen to the lab for testing, to test whether a person is living with HIV or not. And obviously, we do some confirmatory tests to confirm that those that are positive are truly positive, and those that are negative are truly negative. Once a person has been confirmed to be positive, we then conduct another test, which we call an HIV incidence testing, which is a test that we use to check whether a person was infected with HIV within the last 6 months, and we do calculations now to annualize or to compute HIV incidence, an indication that will give us an indication of HIV incidence as explained earlier on. Another test that is done with another spot is ARV testing, where we test whether the person living with HIV is actually taking any of the ARVs that are provided in the country. The next test is that of viral load suppression. Well, not viral load suppression, is to test the level of viral load so that we can determine whether a person is virally suppressed or not. So we'll speak about the results coming out of this test in a minute or so. Excuse me. Okay. Now coming to the results in MPUMALANGA. Okay. Now we'll start with the response rate, the level of participation among members of the households who were invited to participate. A total of 2,692 visiting points were approached, and 92% of these were found to be valid. Valid in the sense that these were households where there were people that were living in these households. Now, from these valid households, 85% of them agreed or completed a household questionnaire. So you can see that one of the challenges that we have is that not all households agreed to participate. And that is where now, colleagues, we need to work together in encouraging people to open their households and encouraging people to participate in the surveys. Now, as you can see that once our data collectors are given the opportunity to conduct the survey, that is, of the 85% of the household that have agreed to provide or agreed that a survey could be conducted, individual response rate goes up to 98%, even above 98%. And this is a very good response rate. So you can see that almost we didn't make it. It would have been nice to be at 100%. So you can see that once our data collectors are allowed to get into a household, the chances of people participating, especially in the province of MPUMALANGA, goes high up. So, of those that were interviewed, the 98%, a further almost 64% of them agreed to provide a specimen. You can see that is way lower than the 98% that completed a questionnaire. So we do need to encourage people to actually, over and above agreeing to be interviewed, also to provide a blood specimen. Now, one of the encouraging things that we observed in the province of MPUMALANGA is that actually the chances of males participating were almost as high as the chances of females participating in this survey. And this was really great, colleagues, because in most of the provinces, because generally in the country, males tend not to want to participate in these surveys. And in the province of MPUMALANGA, if you look at the completion of questionnaire, it was 97.1% among males compared to 98.4% among females. So participation in MPUMALANGA was really great. And if you look at specimen response, obviously among males was slightly lower than among females, but still considerably higher. At 67%, and among females, also as high as 73.9. But of course, the more we get people to provide specimen, the better for our results, and also are able to provide more statistics at a much lower level. Okay. Now, HIV prevalence. Where are we as a province? The prevalence of HIV in the province of MPUMALANGA is at 17.4%. And this translates to a total of 89,000 people living with HIV in the province of MPUMALANGA. Now, obviously, 17.4% is lower by 2% compared to 19.4% that we had in 2017. Now, in terms of absolute numbers, it's 890,000 people living with HIV in the province of MPUMALANGA, which is about 30,000 more people in 2022 that were found to be living with HIV compared to 2017. And obviously someone will say, but how does it work? Because the proportions are going down. It's 19 versus 17%, but the numbers of people, the absolute numbers are going high up. Okay, well, the reason is simply the following. The prevalence of HIV is the proportion of people living with HIV over the total population in the country. So which means if more people are born HIV negative, that adds on the denominator, then the proportion will go down, which is the prevalence. But the absolute numbers of people, if no one was getting infected and people were living longer, the absolute numbers will remain the same. Okay. However, it did not remain the same. 30,000 more people actually were found to be living with HIV in 2022 compared to 2017, which could actually be an indication of 30,000 people that got infected from between 2017 and 2022. So we just need to understand these statistics in a way. So again, these are the statistics in the province of Limpopo, but again we need to MPUMALANGA. Yeah. You know, I can't get away from the trauma when I could not pronounce the province name correctly. So, yeah. So, the 30,000 people are a concern. And again, we need to understand these statistics in the context of people living with HIV being on ARVs. But we'll talk about that a lot more in details going forward. Now, if you look at the order of the provinces from the one that has the highest prevalence to the province that has the lowest HIV prevalence, MPUMALANGA, it's at 17.4%. The prevalence of HIV in MPUMALANGA is highest compared to all other provinces. But again, remember, colleagues, we need to interpret the statistics in the context of people being on ARVs. For example, I'm not saying it's what the numbers will tell me. When people are living with HIV and they are on ARVs, those people are more likely to live long. Those people are more likely to be virally suppressed, meaning that every time you do a survey, you're more likely to find them. But if few people are living with HIV and they are not on ARVs, they are more likely to die than those that are on ARVs and are virally suppressed. So always when you look at the statistics of HIV, we need to look at them in the context of how many people actually are living with HIV and are on ARVs and are virally suppressed, because those people are more likely to live longer. And let's look at the numbers going forward. But at the moment, MPUMALANGA, in terms of the proportions of people living with HIV, the percentage, they have the highest proportion of people live with HIV compared to other provinces. Again, I'll emphasize, we need to look at that in the context of people being on ARVs. So, now, let's look at the profile of HIV by age group between the two survey years. Now, let's start here. This is the 2017 graph. If you look among young people, among these ages, we see that the 2017 graph is higher than the 2022 graph. And this actually, it's an indication that in 2022, there were actually less new infections than in 2017. Because remember, if young people, for example, are born HIV negative, the only way they can acquire HIV is not through birth because they were born HIV negative. It's by other means, sexual behavior or whatever. Let's say sexual behavior, for example, here. You can see that in 2017, a 15 to 19-year-old, the prevalence was 8.6, but in 2022 is 6.3. So it has gone down. So which means actually there are fewer prevalence among young people. It's in a way an indication of HIV incidence. So there are fewer new infections among young people than we had a situation in 2017. But of course, the prevalence among young people, 15 to 19-year-old, of 6.3%, and we go up to 2024, 20 to 24, the prevalence of 8.8% is still very high. So the question is, how are these young ones getting infected? What about sexual behavior among young people? So there's still a lot more work that needs to be done to bring infections much lower than these numbers. Okay, because if you look, for example, at about 3% 0 to 14-year-olds, that's say about 27,000 children 0 to 14 are still living with HIV. So those are still quite high numbers. Now we can see that the HIV epidemic is actually shifting towards the right-hand side. So it's, in a way, it is aging. People are living longer with HIV, and most probably that's due to people being put on treatment. Now, if you look, for example, in 2017, the peak was at 39% among 35 to 39-year-olds. But this time around, the peak has shifted towards the right-hand side, which means epidemic is aging, which is in a way good news because people are then living longer with HIV. However, this peak was 39% in 2017. The peak has shifted towards the right-hand side, but it did not remain at 39%. It went high up. From 39%, it's up to 40.8%. So which is an indication that there could be new infections actually that happened in this age group moving forward. And take it back, remember, earlier on, 2017, we had 30,000 more people that were found to be living with HIV in 2022 compared to 2017. So you can see that even if the epidemic is aging, people are living longer, but there are still people who are getting infected with HIV. And that could be due to unprotected sexual intercourse, more people not being on treatment and therefore not virally suppressed. So those are concerns, and those are things that we need to look at. Now, again, HIV prevalence is 3.5 among the 3% in the 0 to 14-year-olds. Again, males and females. If you look at overall, females slightly more likely to be infected with HIV. But something interesting among young people, if you remember the programs that were targeting women, for example, young girls, adolescent girls and young women, for example, your DREAMS programs and all that. In most cases, the prevalence of HIV actually in this age group is higher among young girls compared to young boys. But you can see here that actually it's lower among young girls compared to young boys in the same age group. So of course, whatever that we are doing with among young girls, we need to continue doing. but it should not be at the expense of young boys. We should not put interventions here and compromise other groups. So again, we can see that the prevalence of HIV goes high up by age, and obviously it changes by age. Older people more likely to be living with HIV compared to young people. Most likely, those that are old are more likely to be on ARVs and more likely to be living longer. Now, if you look, for example, by geotype, in the areas, in the rural areas, in the farms, for example, the prevalence is much higher in those areas, followed by the rural, informal, your traditional rural areas. Now, coming to the districts, we see that Gersband had the highest, is the district that has the highest prevalence of HIV compared to other districts at 20.5%. Okay, 20.5% of people in the districts of Gersband are living with HIV. And the one in Kangala is the lowest at 13.1. But again, let's keep this in mind, and we look at viral load suppression and also exposure to treatment. Now, antiretroviral treatment. You remember that the proportion of people living with HIV was highest in MPUMALANGA compared to all other provinces. Now, the proportion of people that are on ARVs in the country has improved from 2017 at 63.7% up to 80.9% in the country by 2022. And the province of MPUMALANGA is higher than the average, which is at 81.8%. So what does this mean? For example, it tells us that of the 890,000 people living with HIV, just almost 730,000 of them are actually on ARVs. Okay. However, that also says to us just over 160,000 of people living with HIV in MPUMALANGA are not on treatment. And that should be our concern. That should be our concern, because those that are living with HIV and are not on treatment are less likely to be viral suppressed. And then, in the case where they are having unprotected sexual intercourse, they are more likely to transmit the virus than otherwise. So, these are the statistics of treatment. Now, females are more likely to be on treatment compared to males, at almost 84% compared to 79% among males. So we do need, again, to encourage males to get to know their status and also be put on treatment. Now, by age group, you can see that among the 15 to 24-year-olds, they are the ones that have the lowest chance of being on treatment compared to other age group. 56.4% of those that are aged 15 to 24 are on treatment. Other age group, they go up actually all above 80%. So we have a situation where we need to do more work among young children, get them to know their HIV status, and also get them to be put on treatment. Now, among the 0 to 14-year-olds, you remember we said there are 27,000 children that are age 0 to 14 who are living with HIV. However, when we wanted to calculate of those that are living with HIV and they are 0 to 14, how many of them were on ARVs? Well, the numbers were so small for us to be able to do any calculation. And that is a concern, because it says of the 27,000 children that are living with HIV, a very few of them are actually on treatment, such that we can be able to calculate or do the statistics. So, again, indicating to us that we've got so many children living with HIV, but they are not on treatment. And that's the 0 to 14. And if you look in the next age group, the 15 to 24-year-olds. We've got so many children, again, living with HIV, but they are the least likely to be on treatment, and that is a concern, colleagues. Now, a little bit encouraging that a province that had the highest prevalence of HIV, also, it is more likely to be the, sorry, not a province, a district, also in the very same district, it's got the highest proportions of people that are on treatment. So it is always good that where there are more people living with HIV, also the chances of them being on treatment must also be higher, so that we push to make sure that almost, as we know, our target of 95, that more than 95% of them are on treatment, and obviously, hopefully, they all get to be virally suppressed. Now, coming to viral load suppression, again, in the province, overall in the country, we had 61 in 2017, 81% in 2022 of people overall being virally suppressed. Okay. Now, again, we see improvement in the province, that from 60% in 2017, the numbers have gone up to 82.5% of people being virally suppressed. And maybe I should just indicate that in this survey, when we're doing the computation or the test, we are only, the cutoff point of viral suppression is 1,000 copies. So if you are less than 1,000, then you are classified as virally suppressed. If it's above 1,000, your viral load, then you are not virally suppressed. Now, what do these numbers tell us? It says to us about 156,000 people who are living with HIV in the province are not virally suppressed, meaning that those people, if they have unprotected sexual intercourse, they are more likely to transmit the virus. As my colleague has indicated, the issues of U equals U. So we do need to do more work and identify who these people are so that they can be put on treatment and so that they could be virally suppressed. And again, the numbers show that by age group, those that are old are more likely to be virally suppressed, and most likely, they are more likely to have been on treatment longer than the young ones. But again, you can see that the viral suppression among young people is the lowest. Only 73% of 15 to 24 that are on 15 to 24 that are living with HIV are actually virally suppressed compared to others that are above 80. Of course, it's not at the levels that we want. So again, there's a lot of work that we need to do to encourage people to know their status, encourage people to get a treatment so that they are more likely to be virally suppressed. And again, the levels of viral suppression by district, Kharisibanda had the highest prevalence, the highest proportion of people on ARVs, and also the highest proportions of people that are virally suppressed. So that is actually the pattern that we would want. But of course, I wish, and I would have loved to see the numbers being high or above 95%. It would have been great, because then we'd have achieved, well, my colleague will explain, but we'd have been close to achieving our 95 target. So, but colleagues, this is the overall population viral load suppression, the statistics by district, and now my colleague is going to take us through the statistics about the 95 target. My colleague Edmo, over to you. Thank you, colleagues.
Okay, thank you, Prof. Zuma. I'm going to talk about the 95 targets, but before I do that, let me welcome everyone. Colleagues from the department, National Department, from Provincial Department, our civil society colleagues, as well as our partners. Good morning. I'm Edmo Marinda, I'm a research director at the HSRC and one of the co-PIs on this project. I'm going to talk about the 95 targets, but before I do that, I need to just explain, a few things. if you look at the figures that we normally use, or the national uses in terms of planning and everything else, they come from the Tembisa model. People may actually ask, why are the Tembisa estimates different from what we're actually reporting here? All these methodologies are trying to estimate the same thing, right? If you think about our survey, it's a snapshot, right? We're going to communities, grabbing a group of people, we test them for various indicators. Do they know their status? Are they on treatment? And are they virally suppressed? So it's a cross-sectional look at that particular time. If you look at the Tembisa model, what they are basically doing is they are taking our estimates, they are taking the antenatal surveillance estimate, the estimate in terms of key populations, how big is that group, and then they model that and then say HIV prevalence is at this rate, infection rates are actually, new infections are at that rate. If you look at all those methodologies, as I said, they are all trying to actually estimate the same thing. If we go to look at, for instance, at your antenatal estimates, you're actually using healthcare data to estimate what, how many women actually are infected. So I think it's important, in a sense, for us to actually be aware that, in fact, we've got different estimates, but they are all trying to actually estimate and quantify the same thing. So that's one thing. And then the other thing, that Kangalana actually mentioned is that if you look at viral load suppression, for instance, we're using a cutoff of 1,000. If the national figures are using something else, we can count viral suppression, viral particles lower than 1,000 now. And therefore, if they are reporting viral suppression which is below 1,000, then in a sense, those estimates can be the same. And then the other thing is, if you look at the 95 targets, the most critical thing is that, in fact, it's not necessarily just a reporting issue. I know in terms of programming, we get excited, we're reporting the 95. But there's a scientific reasoning behind it. So we're saying if 95% of people know their HIV status, which is an entry point to treatment, then they should actually go on treatment. And if they are on treatment, then they should be virally suppressed. And then we can achieve the U equals to U. And with time, you find that, in fact, the number of new infections should actually come down. Because if people are virally suppressed, then it means they are also less likely to actually transmit. So the 95 targets, from a mathematical point of view, and not only from a programmatic point of view, but from the epidemic side, it becomes important for us to actually achieve that. The ultimate goal really is to actually have less and less people getting infected, and therefore the epidemic should actually come down. Now, in terms of let me then go into the results. Can we? Okay, I can say it from. That's tiny. Okay, I'll actually look at this side. So, in terms of the definitions, the classical definitions. Who know the HIV status? People report, I've been tested and I know my HIV status. So we say, they actually diagnosed. That's the first 95. The second one, people on ART. We actually tested, if you look at the study, we actually looked for ART analytes, right? We had to actually find antiretroviral analytes in their blood to say they're actually on treatment. And then viral suppression, obviously, we actually tested that. But there were instances where we didn't have enough samples, but we had tested for viral load, and there was no result for ART analyze. So if a person reported that they were actually on ART, then we imputed that to actually say they were on ART. So self-reported ART here is conditional on them providing a blood sample and having tested for viral suppression. Now, what are the figures that we actually see here? So if we look at the first 95, how many people have gone to get tested and were told their HIV status? The rates are actually way lower than the 95 target. So if you look at it overall, we're looking at 87.3%. The target is supposed to be 95%. And then if you stratify it by male, females, we see that, in fact, males are less likely, about 85% compared to 89% for males knowing the HIV status. This is a critical indicator. We can go on to talk about the second 95 and third 95, but if fewer people know their HIV status, then it means there are people actually living with HIV without knowing it, and it has implications in terms of viral suppression and therefore further transmission. So the first 95, if you look at the target, we haven't even achieved the 2025 one, the 90, when we're talking about 90. Now we're talking about 95%. So this is a way much lower than the target of 95%. But once people actually know their HIV status and they are likely to actually go on treatment. So we see that the second 95 is actually 94.5, which means we're actually achieving the second 95. But remember, it's conditional on having a good first 95. And then those people who are actually on treatment, 94% of them were virally suppressed. These are conditional, unlike the ones that Prof. Zuma actually presented, where we're talking about the population level of all the people who are living with HIV, how many are virally suppressed. Now, if we stratify by age, we find that, in fact, young people are not doing as well as older people. The rates, the first 95 for 15 to 24 is 71%. And then on art as well, it's also fairly low, about 80%. But of those people who are on treatment, 95% are virus suppressed. So with young people, I mean, we're not doing very well in terms of people testing, knowing their status, and then for going on treatment. But once, people are a little bit older, the rates are a little bit better. 25 to 49, we are looking at 88%, 96% for the second 90, and then 94% for viral suppression. And then if we stratify by district, we find that, in fact, the district that's doing fairly well is Gesibande with 94%, 92, 93%, 93% for the 95-95. The other districts still not well in terms of the first 95. That's where the challenge is, with the other two districts. We didn't present data on the stratification by urban, rural, but you find that, in fact, the challenges for the first 95.
Thank you so much, colleagues. Like Prudence has mentioned, I'm Rindizani Magobo. I was one of the project managers for SABSSM. So I'll just continue with the key drivers of HIV, and then Prudence has just touched on the consistency of condom use during the recent sexual intercourse. Then I will go on to touch on the self-reported circumcision. So in the survey year 2022, we saw an increase in the number of respondents. These are male aged 15 years and older who have reported that they were circumcised, and this was an increase from 60% in 2017. And from MPUMALANGA province, we also saw a substantial increase from 63.7% in 2017 to 71.8% in 2022. And this was the third highest level of self-reported circumcision at a national level. And when we stratify self-reported circumcision by age and locality type, we saw that those that are aged 15 years and 24, they reported the lowest level of circumcision, sitting at 69.1%. By locality type, self-reported circumcision was the highest in tribal areas at 79.8%. Self-reported circumcision by district, so among those aged 15 years and 24, the lowest was in Gesibande and the highest was in Ehlanzeni. Those aged 25 to 34, the highest was in Nkangala district and the lowest in Ehlanzeni. Those aged 25 to 49, we saw that the proportion was almost the same, but slightly higher in Nkangala district. We also reported by the type of circumcision, which is medical circumcision versus the traditional circumcision. At a national level, the medical circumcision was sitting at 60% versus 39.2% for traditional circumcision. And in MPUMALANGA, most of the respondents sitting at 68.1% reported being medically circumcised versus 31.4% who reported traditionally circumcised. When we stratify circumcision types by different demographics, starting with the age, we saw that those aged 25 to 49 were the lowest. They reported the lowest level of medical circumcision, and then with traditional circumcision, the lowest was reported among those aged 15 to 24. By locality type, medical circumcision was lowest among those residing in rural areas, and while the traditional circumcision was lowest among those residing in urban areas. And when we stratify types of circumcision by district, this ranged between 52% in Nkangala district to 77% in Hertsbande. We also looked at the awareness and uptake of PrEP among those individuals who are sexually active, 15 years and above. And the overall, 43% of the respondents reported that they have heard of PrEP. This is the level of awareness of PrEP in the province. Among those who have heard, 8.4% reported that they have taken PrEP. And among those that have reported that they have taken PrEP, 3.2% were currently taking PrEP. And when it comes to the willingness to take PrEP, 54% did express that they are willing to take PrEP. And then when we look at the awareness and uptake of PrEP by district, we found that the lowest number of awareness of PrEP was in Ehlanzeni district. And in terms of those who are taking PrEP, the lowest proportion was in Nkangala district. And those who are taking PrEP, 0.9%, which is lowest also in Nkangala. And with regards to the willingness, the highest number of individuals who said they are willing to take PrEP was in Nkangala district at 64.6%. And then we also looked at the HIV, the recent HIV testing among individuals aged 15 years and older. And if you look at the bar graph, the yellow or olive represent female, the blue is the males. When you look at those aged 15 to 24, we compare females to males, 19.7% of the females reported that they never tested for HIV, compared to 34.2%, which is a bit of a concern in the male counterparts. And among those who are aged 25 to 49, the males accounted for 4/4 of the proportion that reported that they never tested for HIV, sitting at 14.4% when you compare to the 3.1% of the females. So this is a concern. And among those who are 50 years and older, the proportion of those that reported that they never tested for HIV among the females and males were the same. So I am going to hand over to our CDC colleague, Dr. Pelagia Marangandi, just to come and give the concluding remarks and some of the actions for recommendations. Thanks.
Thanks, Rindy. Good morning, everyone. All protocol observed. My name is Pelagia Amrangandi from CDC, and I'm going to take you through the last remaining slides. Okay, so just to highlight a few points from the data that has been presented just now, we see that there is a shift in the HIV epidemic towards older age categories. If we remember the slide that Prof. Zuma presented, which signals a stabilizing epidemic. We also see that there are disparities in the burden of HIV, with HIV prevalence 1.5-fold higher among males aged 15 to 24 at 9.8% compared to females of the same age group at 6.3%, which is something that we don't normally see in other areas. And we also see that there is a 1.6-fold higher HIV prevalence among females aged 25 to 49 years at 31.9% compared to males of the same age group at 19.9%. We also see that there has been an increase in ART coverage and viral load suppression rates between the 2017 survey and the 2022 survey. And for circumcision rates among males, we see that it increased with age, with medical circumcision being the highest compared to traditional circumcision. And on PrEP awareness, it's at 43%, and uptake at 3.2% was universally low across districts. But willingness to take PrEP was also relatively low at 54%. sorry, wrong direction. And with this, what can we look at? We need to consider a long-term strategy to care for individuals in an aging HIV epidemic. We saw that the epidemic is moving to the right, which is the older age groups, and heightened focus on campaigns such as U equals to U and other strategies to promote uptake and sustained use of art, especially among young people and adult men, and tailored interventions to address the health inequalities affecting testing and treatment rates at district level, and continued focus on increasing VMMC uptake among uncircumcised males aged 15 years and older, and to enhance accurate public awareness of effective HIV prevention measures, including regular HIV testing, condom use, and PrEP. So with this, I would like to thank everyone in this room for coming and listening to the findings. And this is a picture of field workers who participated in the survey. Would also like to thank them for their effort. In addition, this work wouldn't have been possible without a consortium of partners led by HSRC, and these include the US Centers for Disease Control and Prevention, CDC, the South African Medical Research Council, SAMRC, National Institute for Communicable Diseases, NICD, University of Cape Town, National Department of Health, South African National AIDS Council, UNICEF, and USAID. And the funding source for this survey was President's Emergency Plan for AIDS Relief, PEPFAR, through the Centers for Disease Control and Prevention. And these are the contributors to the survey, and we also like to thank everyone who supported this effort. Thank you.
Thank you so much, Dr. Pelagia Muragadi, Dr. Rinzizani Magobo, Ms. Prudence Chambale, Professor Edmo Marinda, and Professor Kangalani Zuma for the HSRC presentation for the key findings of the 6th South African National HIV Prevalence, Incidence and Behavior Survey for MPUMALANGA Province. So colleagues, we are now going to work in the small groups that we have been allocated to. So as we had mentioned earlier on, there is an HSRC facilitator in each table. Perhaps they can just raise their hand if you have not been introduced to them. That person will then lead the discussion. If you can just raise your hand, colleagues, so that they can see you in each of the tables. There should be representation across all the tables. If there isn't, then we will come and support that. Sandisiwe, you being there, of course. So this person that is on your table will be leading the discussions. There are questions that are on your table. They will indicate which specific questions your table should be dealing with. Afterwards, you would then also select your representative or a person that will speak on your behalf, and also make sure that they cover all the points that you have raised. We'll then, through Mr. Sithole Nkosi, who will then lead those discussions, just take a representation for each table just to share your thoughts. So these discussions should not take longer than an hour from now. So we'll just allow each table to then continue, and note that as you discuss, in some tables we'll be recording these discussions just so that we're able to transcribe and be able to provide a summary of how the discussion transpired. We'll also be typing in some of the discussions in each table. We have a colleague that is allocated to just type and summarize what is unfolding there. So we hope that you are also comfortable with that. In terms of the presentation, I've seen that some colleagues were taking pictures, others were asking how they would access it. So once all the approval processes have been finalized, we'll make sure that Prudence and Rindy are able to share the presentation with the colleagues. Obviously, it's going to be through Mr. Ngosi's office as the coordinating team in the province, and they'll ensure that you will be able to get that as soon as we are able to share. So colleagues, please start the discussions, and if there are also any questions, we would also be able to answer those questions in the small tables as well. Thanks. And the colleagues online, while we do that, please note that we will then be back after an hour. Shandir, what is the time now? Okay, so we should be back by 10 to 12 so that you can listen into the shared discussions. Thanks. They will be speaking from.
Yeah.
Okay, maybe I can give them the instruction. Okay. Colleagues, so Mr. Nkosi will be moving from one table to another. In each table, we ask that the representative should just stand up so that we have colleagues that are also connected online so that they are able to see you. And then you will introduce yourself in terms of your name and the organization that you are coming from. And then you can just indicate what input comes from the people that are sitting from you as well. So the tables that are ready can already start. Mr. Nkosi will just facilitate that. Thanks.
Which tables are ready? Let me see by the show of hands. Okay. Yeah. All right, colleagues, can we have your attention because we're all answering different questions, am I right? So as they report back, please listen to their report because you will also benefit from their report, and there might be a need for you to make input, especially the colleagues that are coming from the province to say, we think over and above that, this is what we should actually add. But for now, we're just actually saying, please tell us what has been your discussion, okay? And then I've noted two tables that are ready, table 6 and table 1. All right, let's start with table 6. And please introduce yourself, who you are, and which sector are you representing in the province. Whether you're coming from government, you're coming from an implementing partner, indicate whether you are actually a PEPFAR implementing partner, Global Fund implementing partner, so that we understand you know, where you come from. Thank you very much. Over to you, table 6.
Okay, is it still, it's before 12, 5 minutes before 12?
Good
Good day.
Just a sec, thank you. Colleagues, if they happen to mention something and it was also raised and mentioned in your group, in the interest of time, let's not repeat it. So that we actually mention, I think they've got an opportunity to mention everything, but the second group, second, third, fourth, they would actually then be taking a cue from what would have been presented. Will that be fine? Thank you very much. Go ahead, ma'am.
Good day, everyone. My name is Vuyokazi. I'm not going to say the other one. Vuyokazi Vim Shiwa. I work for the Department of Health in MPUMALANGA. I'm based at Hlanzeni District. I'm under the HAST Directorate. I'm the MNE officer there. So I'm representing table 6. Our question was question 2, which reads, what HIV messaging is critical to communicate and to whom? All right, so the first, the question is, has got sub-questions, obviously. So the first one is how do we reach and empower adolescent girls and young women? Where should we focus and how? So we said we will reach them. Okay, first thing, we should know where they are. We should identify the spot where they are. Secondly, we'll find them through social media platforms by use of targeted messaging. We will find them also at safe spaces, youth zones and youth corners, community youth and development centers, church communities through the Sunday schools and youth camps. And one key thing is we should find them earlier before they are actually at the age of being adolescent. And then, okay, where should we focus and how? So our focus will be at looking at DOH and DOE policies that needs to be reviewed, because as we discussed here, we find that there are restrictions when it comes to the policies of DOE, which actually are restricting to us as DOH to reaching out to the youth. So that needs to be reviewed. And also, we should use the pastors forum and traditional councils. Those are the key leaders that will also assist us in ensuring that we get the focus through health education and also the initiation schools. We're looking at the boys here. And then we should also have collaboration between parents, SGBs, and the department. So that will be our focus. Second sub-question, how do good role models in younger groupings influence behavior? This one. Yeah, no, we had a discussion here that we need to actually define the role model. And we felt that the youth, somehow they don't understand the role model. We've got role models and we've got influencers in this day and age. We've got influencers, so the youth are not getting it correct. So we should clearly define the role model and the influencer. And then, what we need to do is, we should also have I'm distracted. All right, the departments as well, they should identify role models. We have role models that are the people that can be role models, but they need to be identified. We've got programs that, like Your Dreams program, where we have ambassadors from there. We should have more ambassadors that are going to be able to talk to their peers and share the messaging and become role models. We also have, we should also have role models within our families. As we were discussing, we were like saying that, our kids, they don't see us as their parents or their sisters or their brothers as role models. They rather, when you ask them who's your role model, they'll talk about somebody who's outside of the household, someone that they don't even know. So it talks to us as well, and it is asking, what are we doing, Tina, as parents, as brothers, to show that we are role models? So we should look at that. And also we also spoke of the issues of roping in departments of arts and culture, because we spoke of the issues of the influencers. the programs that now we have on our television that our youth are watching, and also the celebrities, how do they portray themselves towards the community so that they can become role models. And so I think I've covered both that. So then the third sub-question is, has U equals to U been successful in the province? And what could be done to further UNU campaigns? Here we said it has not been successful. Reasons being that there has not been a rollout to DOA in the of the guidelines within the province, though there was a training that was conducted last year, towards the end of last year, but the rollout still needs to take place. So what needs to happen is we need to roll out to DOH and other stakeholders the UNU guidelines. We should also come up with key messaging that are clear and that are easy to understand so that our community are able to understand what is U equals to U talking about. So I think that's all that we could report on as table 6. Thank you.
We're moving now to table number 1. Let me see by the show of hand who will follow table 1. Please shout the number. Table 1, over to you. Shout the number of your table. Okay, it's going to be 3 and then 10. 3 and 10. All right, over to you, sir.
Thank you very much, Party, and all protocol observed. My name is Ronald Sibui. I'm from the Institute of Health Program and Systems. We are implementing an AYP program in Bombela, funded by Global Fund through our AIDS Foundation as our prime recipient. Thank you very much. So we were looking at question 1 around the lesson learned, and we didn't use the question that were given as a guide, but we just brainstorm across what worked and what didn't work as a lesson learned. And part of that is that MPUMALANGA is so fortunate to be, I think all our districts are funded by Global Fund and also by PEFA. So, I mean, when you look at PEFA funding is covering all our 3 districts, which is a good thing that is happening in MPUMALANGA. And when you look at Global Fund existence in the province, even though it's covering 2 districts, but you can see that there's money, HIV money coming in the province of MPUMALANGA, which is a bonus for us as a province. But we also identify that as much as there's money that is coming in and is covering all the districts, there are some sub-districts in the province which are not having enough resources or having footprints of partners that can assist. And one, we were speaking about SABSSM as an example, where money is not flowing in for HIV in terms of implementation for partners. But we also spoken about an active civil society from the provincial level, district, and the local level, which is a good thing. And also an active, I think we have an active head of secretariat in the province in all levels. I mean, at the provincial level, we are, as partners, we are held accountable every month, every quarter, where we are able to go and sit and report in terms of the activities that we are doing, we are implementing in the province. So we also spoken about that there's still a need for collaboration between the intergovernmental collaboration, I mean, between the number of various departments I mean, one of the elements that we're speaking about, that as an implementation partner, you will be called by the Department of Education today. Tomorrow you are called by Department of Social Development to come and report the one and the same thing. And if there were collaboration, you could use one platform where you can go and report to all of them. Because we sometimes we spend a lot of, as implementation partners, we spend a lot of time in meetings reporting than giving out strategies and for implementation on the ground. So that collaboration, especially amongst government departments, is needed. Part of our other observations that we spoken about is what strategies in terms of preventions that we have, and we touch men in particular, and we're looking at the number of men that are using PrEP in the province, and one of the things is that men have information around HIV prevention. They know about PrEP. If you can go and sit in a car wash on a Sunday, men, as much as their discussion may start with GNU, speak about Kaiser Chiefs being on #1, but it will end up men speaking about sex. So they will end up speaking about sex, and they will tell you that if I want to sleep with so-and-so, I will take PrEP for 7 days. And if I move from this one partner to the next partner, when I'm preparing to sleep with the other partner, I will also take PrEP for me to target that one partner. And it covers that particular point where it says in MPUMALANGA men have multiple sexual partners. They have that information, but the challenge is that they are not using that information correctly. And they will have information around also PEP. They will tell you, if I didn't take PrEP, I will go take PEP. So they have that information, but the information is not used correctly. So it speaks to, because in MPUMALANGA we had programs that speaks to men. We had Coach Impilo that were speaking to men. We had men championing other programs. But I think our challenge is the information correct, the messaging? Have we sat down and give men that particular correct information? And are we targeting men where they are? Because, I mean, in our programs, we go to car washes during the course of the week. But the problematic men come there on a Saturday and a Sunday afternoon, and we are not working on a Saturday and a Sunday. So we are targeting the car washes during the week when the problematic men, the one that with money and money to buy, the one that are sleeping with AGYWs, they are not there during the week, but they are there on a Sunday. So maybe we need to start to think about working over the weekend to target the one with money, because those are the ones that are problematic. Because the 45-year-old man that has money, that is driving a Mercedes, is dating a 17-year-old girl that is attending MPUMALANGA University or any of the TVET colleges. So the other issue that we've spoken about around prevention is our facilities as a lesson learned, they are still not yet men-friendly. Hence, you don't see men during the course of the week going to facilities. But we have seen men coming to community implementation partners to take PrEP in the community, because they know that it's quick. And then I'm not charged, and the whole process will take less than an hour. So in the community, men are coming to take PrEP, but in the facility, you won't find men. Even if you go during the day, you will find females only or women only, but men are not there. But if you go to facilities, 7 o'clock in the evening, when the nurses are changing the shift, men are there to take their ARVs. 7 o'clock as the new nurses are coming in, the tired nurses are going home, men are coming in to collect their ARVs. So we also need to think about that thing. So the other issues as lesson learned in MPUMALANGA around HIV prevention is that our HIV prevention or PrEP initiation, and I'm speaking because I work in a community setting and with AGYW, we have PrEP initiations that are event-driven. So if ANC January 8 is coming, that particular week before the ANC January 8 event coming, AGYWs are preparing themselves. They are taking PrEP in high numbers. But after a month, in terms, you will see 1,000 AGYWs taking PrEP in Mbombela. But after a month, in terms of PrEP retention, you will only get less than 1% of them coming to retain PrEP. Towards Valentine's, they are taking PrEP again. But after a month, when you start searching them to come and do PrEP retention, they are no longer there. University freshers ballers, they are taking PrEP again. But TROP is always lower. So those are some of our drivers and our challenges. And the other thing is that when you see high numbers of PrEP going up, you will also see high numbers of STIs going up in that particular period and for that particular cohort. But you'll also see numbers of teenage pregnancy going up for that particular cohort. So those are some of the elements that we have seen in MPUMALANGA as part of the drivers for HIV and also but for HIV prevention. But we were, funny enough, we're speaking about men, speaking about sex in the kawashes. In this table, we also started to speak about impesu. And we said traditional medication can also be a counteract for HIV, for ARVs. I mean, we also spoke about, what do they call potato, African potato. So men knows, I mean, a lot of men, they have their own, they have their own iskupu nyana, 1 liter iskupu in their car. The 1 liter of iskupu is for sexual enhancement. They are taking ARVs, but they are also taking this 1 liter skupu that is sitting in the back of their car, and their wives don't know that they are enhancing their sexual activities. That 1 liter of skupu has African potato or has mpesu, and they are taking more than what is prescribed. They will tell you, not just take a little bit, they are taking too much, so that it's, you understand. But that also has a what do they call medical term? Contraindication. Yes, angithi ngumfundisi, so we speak about, so there will be those drug interaction in terms of, so those are some of the things that we spoken about. Thank you very much.
No, thank you very much. The next table is table number 10. Oh, sorry. Or, do you feel threatened now? Such that you want to? All right. Can I have the other mic from the tables that have spoken? Okay. So I've actually noted table number 3, table number 10. Can I note another table? Table 2. Table 4, table 2, table 7. All right. Go ahead, table 10. Table 10, you've given them, you've given them. All right. Go ahead. Thank you.
Good day. How are you? Good. Yeah, my name is Priscilla Kitwis Melane from the AIDS Foundation of South Africa, Provincial Manager. All right, colleagues, so we focused on question 2, which says what HIV messaging is critical to communicate and to whom. So the first question is, how do we reach and empower adolescent girls and young women? Where should we focus and how? So our response was to say that we need to identify the key hotspots on where to identify the young girl in the community. And then once you have now found this young girl, you need to make sure that when you approach them, you use a comprehensive approach where you make sure that you focus on this young girl in a biomedical aspect, in a psychosocial aspect, and also in a behavioral aspect. Because when you're dealing with a human being, colleagues, you need to deal with them entirely. And our problem is that sometimes we focus so much on biomedical approaches that we forget about the other aspects which now empower this young girl to behave in certain behaviors, right? And then we also said that once you've found this young girl, colleagues, you need to make sure that you keep them, Because the minute you lose them is when we have the problem. When you found that young girl HIV negative, you need to make sure that when they graduate out of your programs, they are still negative. So not just go there to reach numbers, but just to make sure that you keep them with you constantly. And then we also said that I mentioned that you need to use the comprehensive approach, which means you need to deal with them in a biomedical, behavioral, and psychosocial. Make sure that when you empower them, you're also assisting them on programs like your economic intensive programs, where you make sure that you also leave them with a skill, colleagues, especially our young girls who are out of school. They are out there, they have no hope. So make sure that you leave them with a particular skill, which is showing them how to start a business, showing them how to sew. So such programs, we need to make sure that we are going to empower the adolescent girl and young women. And then I think while we were also discussing, we also saw that we are doing well with the girls. I think from the report that was shared, we can see that we're doing well with the girls, but what about the boys? So we need to make sure that we also have programs that are inclusive of the boy child as well, because there's no need of dealing with the girl where else the boy is being neglected. And then we also said that we need to have more ambassadors in the communities who are also working and trying to find, especially the AYPs who are roaming around in the communities. And we need to make sure that these ambassadors that we're going to have form a collaborative approach from ambassadors that we're getting from DOE, DOH, and also DBE. Yeah, I think something like that, okay? And then the second question says, how do good role models in younger groupings influence behavior? One of our group members here identified the Indoni program, which focuses on keeping your virginity, and it also promotes good behavior. So I think such good programs are the ones that are happening here around in our communities. And then the third question was, has U equals U been successful in the province? And the colleagues here in the group, they were saying that if U equals U was working, then viral load suppression would be achieved as 95, 95, 95. So clearly it's not working. So enough is not being done on building capacity in terms of the U equals U campaign. And then we also said that a workshop on U equals U was attended, but there has not been a launch yet. I think my other colleague did raise it on the other table. So I think that's something that we need to look at as a province, to make sure that it will be successful in the province. No, thank you so much, colleagues.
Thank you very much from Group 10. Let's move to Group 3, or Table 3 now. From Table 3, we're moving to Table 5.
The other one works quite well also. So what we had discussed is table number 3 was that we are still finding that our communities and our men, especially in Kangala, the rural areas, still prefer the traditional circumcision. And we were thinking that how can, maybe we can integrate, the two, make sure that Department of Health works with our traditional leaders and make sure that we tighten that relationship while we make sure we accelerate service delivery through the very same traditional structures that have been formed. But much has been done by the department to integrate the two, making sure that they tap into the traditional space and making it available and safer for our men. So we are hoping that that can continue and we can put more effort into making sure that it reaches all the corners of the province. And then we also said that the issue of gender, and norms in the community where women are not really exposed to talking about male circumcision, especially in our traditional areas, it's still a barrier where men, when you go to the Nkosi, I remember once I was supposed to go and talk to the Nkosi and I was wearing a trouser. They said, no, girl, You can't go there, you know. You need to be dressed appropriately. The Nkosi won't allow you in with your trousers. So that is still a barrier. As a healthcare person, when you are waking up to go to meet someone, but then there are rules and you need to abide by those as a sign of respect. So we need to make sure that we are very conscious of that as we engage our traditional leaders. And we needed to, we said we need to open the talks in families. Let our boys hear about male circumcision through their fathers. We really need to strengthen the family system in all of our questions. I think in all our responses to all the questions, we said we need to strengthen the family systems so that the talks don't come from external, but they can actually start at home. So if you are encouraging your son to actually go for VMMC, it would be much better for him to hear it from dad, you know, rather than hearing it from a healthcare worker. So let's get the talking happening at home. Let's get fathers engaged in engaging their boys, because that will have a much more impact on them actually taking up the services more than them hearing it from the next person. And I think the next one was, have youth HIV prevention campaigns been successful at reaching its targeted audience? So yeah, the response here is yes. We've seen the numbers. There are some nice declines that were shared with us, but we also feel that we need more intimate campaigns where we actually engage young people at a smaller scale. We had programs such as Zazi. We had programs such as the Rats at schools, where we get to actually engage with these young people in a more personal level and really find out from them what are some of those challenges, because the bigger campaigns, we seem to miss the people that actually we really need to talk to. So I think more close, intimate engagement with young people at smaller scales, but reaching a huge number, and also diving into where the problems are. Because sometimes if you go and do a campaign in Bombela, for instance, but then you know that the prevalence is in Komazi, you are actually missing the point, and you are spending resources where actually they are not needed. So let's dial it down and make sure that we actually engage them at a level where we can get them to actually talk to us. And then the last one is, have HIV prevention strategies for men been successful? And what are the best practices for, yeah. So I had to put it about no men in my clinic, they are not comfortable. And then we were saying, Lana, but if there was a tavern underground, you know, even if they say that they are going down underground with a rope, they will go down there. Nothing wrong with the clinics. But there have been MENA campaigns that have been done. We had One Man Can, which was a very good program actually to engage men. So we have had programs, and I think we will continue to have programs to engage men. And what we have learned through those programs is that the delivery, if it's done by men, it's more engaging. So we need to make sure that we continue, as much as we want to diversify and empower all genders, but men talk better with other men. They open up better, and they engage more. So we definitely need to make sure that we amplify programs that target men, but not only men, but boys. And maybe create a platform where we can have those intergenerational talks within the boys and the men. As we inform and educate men, we are also informing the boys in the very same talks. So we are hoping that the MENA campaigns and the One Man Can continue. And then what we also said was that, can we keep programs that are working? You know, we have had programs before that actually have worked, but it's almost like as soon as we see that we are making some inroads with this program, we cut it off and start something new. So we are feeling that if we can just keep the programs that we see have an impact, that is actually bringing not just the number, but that change. So we need to keep those and make sure we integrate the new information and the new innovation instead of starting new programs. Yeah, thank you.
Thank you very much. Group 3.
Group 4.
Now I'm actually giving to group 5, then it will be 4. In the order of hand raising.
Good afternoon, everyone. My name is Gladys Molahlegi, I'll be representing Program 5. I'm from the Department of Economic Development and Tourism in Nelspruit. Okay. Our focus was on question number 1. The first question is that what are the lessons learned? HIV prevention strategies for men have not, I've started wrong. The contributing factors on HIV prevalence and the shifting towards the older age could be attributed to the following factors. Number 1, ART people, people on ART are living longer and they are living healthy lives. However, most patients are still face challenges with long-term use of ART. For example, in our group, we discussed the issue of the kidney failures. So as the health practitioners, we need to find a way. The earlier, the better. Once the person starts the ART, we need as well to start educating on the failure of long-term use of the treatment. It can also be attributed to a lot of strategies that have been implemented to manage the pandemic. Since going back to the 2000s, we've been educating, you know, there were so many programs implemented in our communities as prevention strategies. So that can as well be the reason. And also we do have accessibility to health facilities where people can get ARTs in our communities. The clinics, we discussed earlier that we do have the 24-hour clinic, you know, everywhere you can get, as well as the private sector has come on board. They are also having the corporate social responsibilities. They are calling the mobile clinics to come and service their employees. And then we also have newer structures and programs that exist to address the issues of the spread of the pandemic in our communities. Another lesson learned is that the behavioral interventions are needed to be able to fight the pandemic. You cannot fight the pandemic alone without fighting the behavior. So we need as well to address the behavior by bringing the behavior change programs in our communities. And then we must not only focus on the UU in isolation, but we need to look at it in combination with other prevention strategies such as the condom use, the PrEP, implementation of other behavior change, and so forth and so forth. Like that group presented earlier on, that the use of other traditional, African traditional medicine should also be looked into how we can incorporate that into making sure that we holistically address the problem. Oh. Okay. MPUMALANGA needs to increase programs to retain patients to treatment, to care and treatment, and to increase the first 95 of the UN AIDS targets. And then going to B, where do we learn, or we and our children learn about HIV? A lot of youth get information from the social media. So we need to intensify that as a strategy of spreading the message on fighting the pandemic. So we need as well to come on board as parents, because we know that some kids, or most of the kids, they learn in schools through the social skills program. And as parents, we need as well to come on board. We need to sit down with our kids at an early age and start educating them. As planning, we need as well to mainstream HIV information and not only confine it to healthcare workers. As I've indicated earlier, that parents, educators, each and every person in the communities we need to take part in making sure that we bring down the spread of the pandemic. A need for intersectoral or collaboration to cover the majority of sectors in the information sharing. We need as well to partner. Partnerships in numbers, we can do more. We need to partner more than to work in isolation. We need as well to involve all the stakeholders that are contributing to social behavior interventions. The last one is have HIV prevention strategies for men being successful? And the answer is that no. Culture played a huge role, e.g. the multiple sexual partners. The research showed that men have more than one partners, but looking into our province, it never gave a room to look into that traditional practice of polygamy. So we need as well to focus on that one. And then in the context of MPUMALANGA, we need to,
Please talk to the mic.
Oh, sorry. In our context, we feel that the research could have focused or dwelled into that, is that this is just an extra or promiscuity, or is a polygamous marriage setting, or what? We need maybe as well to get that segregation in the next research. Key population like those from the mining sector need to be prioritized in the healthcare sectors and strengthen the existing program with the multi-sectoral lens. We feel that, for example, the research revealed that in Nkangala and Gersibande, where there are many mines. So the mine workers, they go early in the morning underground, they come late in the evening, and they are unable to access certain programs in our communities and the medication. So we need to intensify working with the private sector, bringing the mine owners on board to make sure that we together focus our resources towards fighting the pandemic. Thank you.
Now let's give them a better round of applause. We're moving now to table number 4. And then after table number 4 is going to be table number 9. Table number 9. Huh? What table is this? Oh, sorry, it's 2. I thought it's 9, sorry.
9 is ready.
Okay, after table 4 is table number 2. All right, thank you very much.
Thank you, Program Director. All protocols observed. My name is Nkosi Khona Chabalala, and I'm with Broadreach Health Development, supporting the Provincial MPUMALANGA Department of Health and MPEC as a technical advisor on strategic information and MER based in Nelspruit. So with the brief given, we went straight across all the questions. So our discussion was not necessarily based on following the format of the questions, but we covered some of the questions at hand. And one of the fundamental things that when we started discussing, reflecting on the information that was provided to us, the one thing that we all agreed upon was, if we continue in the trajectory that we are continuing in right now, we will not hit our 2030 goals, just based on the data that we saw. And then some of the fundamental challenges that we reflected on included the multi-sectoral approach in our programming and the implementation of some of our specific programs. So we do have plans. Education confirmed, who are part of the table, they confirmed that they do have plans to deal with issues of HIV. Health confirmed they do have plans, but where do all of these plans actually come together to deal with the actual client or the beneficiary that needs to receive all of that we have planned for? So we identified that there needs to be a process of, finding ways and means of bringing all of these plans together and making sure that these plans are informed by data and they are addressing the problems that have been identified already. And we should be able to also monitor and readjust those plans as needed as stakeholders that are needed in responding to the HIV. And then we also spoke about localization of interventions because, you know, the clients or beneficiaries that do access the programs that are currently in place, whether it be Department of Health, Education, and so forth, we realized that some of the information, when they get what they get from health and what they would also get from education, what they would get from elsewhere, is not necessarily talking to the same goals and the vision is not the same. So we found that also there is an issue of a challenge of sharing of information, change in policies, change in guidelines between the relevant departments. So there has to be an improvement on that front. So issue of localization, part of the interventions or all our interventions should be focused on the receivers who are the beneficiaries in the communities. So meaning that the messaging should be tailor-made so that they understand what we actually are trying to say or what we're trying to do as different sectors. And then some of the other challenges that we discussed, which have not been mentioned, are issues of gender-based violence, you know, which then also inform some of the gender power dynamics that have been spoken to, which I won't dwell into details at this point. And I am just trying to check my notes. Then the fundamental or the last point that came out strongly on our side is before COVID, we were quite good at with sharing of information with communities. We had IEC materials everywhere. You saw HIV, TB information on all billboards. And it was also on TV and radio. We had a lot of adverts that were talking to issues of HIV and how it needs to be addressed, and also informing our beneficiaries or our communities of how they can protect themselves and how the programs are actually run. But we seem to have dropped the ball on that one, where we were saying that we need to revisit how the world has transgressed or has moved in terms of, you know, we have social media nowadays. Are we using that space effectively to target specific members of our communities? Are the men listening to radios? Are the men listening to, are they on Facebook? Are they on, are they watching TV? And do we have enough programs that actually target everyone in the community based on where they mostly at? Yes, we can go to ship-ins, but I do not drink. You won't find me at the ship-in. But I still don't go to the clinic. I'm speaking for men. I still don't go to the clinic. I still test through my partner, right? Where am I? I don't go to church. The person that does my garden washes my car. Where am I? Right? So those are the things that we need to figure out as we plan our interventions. Those are the things that we need to be very specific about when we plan our interventions. So we shouldn't blanket things, and it should be specifically focused for that specific community, that specific group that we are looking at. And then in that, with that said, there are a lot of programs that come and go. This is, I promise, this is the last thing. There is a lot of programs, good programs, that come and go based on funding received from either PEPFAR or Global Fund that don't necessarily get adopted into the departments, the relevant departments that maybe those programs are funded through for continuation. So for an example, we're looking at key population programs such as programs that focus on sex workers, and you find that, you know, a lot of effort gets put in for a year or two, and when that funding ceases, then we end up with a situation where that population that was covered then, you know, regresses back to square one until someone else comes in. So maybe we also need to look around, how do we lobby and advocate for some of these programs and ensure that they are integrated into the entire health system? And I thank you.
No, thank you very much, Group 4. Let's now move to Group 2, or Table 2.
Good afternoon, colleagues. I don't know if you can hear me. I've upgraded my voice thanks to flu. Dr. T.G. Matoro, Right to Care. I'll be reporting back on the discussions of Group 2. So we were basically discussing, HIV messaging with 3 questions, reaching and empowering adolescent girls and young women, good role models for young groupings, and the influence on behavior, and also U equals U. So I'll take the questions in order. So for the first question, I think most of the points have been coming up as the colleagues have been discussing. But one thing that was standing out when we were doing our discussion was that there needs to be multi-sectoral collaboration, and we need to ensure that our HIV messaging is aligned with other important messagings, if one may put it like that. So we'll also unpack on that. With the issue of multiple sectors that need to be involved, colleagues have spoken about faith-based platforms where we can find the young people and empower them. We've looked at schools, sports sectors, we've looked at, just trying to see here, and workplaces as well, as other colleagues have been mentioning. Just to add what other colleagues had not discussed in detail, we feel that we need to get to a point of engaging parents and guardians, more especially focusing on men and boys, by allowing them to take responsibility for the power that they have. So as many colleagues have been talking, it's been coming up that men have a number of privileges, and if we can touch on allowing them to act on that in good faith, that would be one of the good starting points. We touched on ensuring that parents are engaged during facility visits, whereby we should be encouraging joint partner visits with regards to sexual and reproductive health reviews. And this would include visits that will start before conception with family planning, preconception, during pregnancy, post delivery, and also ensuring that the children can also come with the parents at the same time. And we also feel that through the involvement of both partners, the empowerment of both partners would assist us to ensure that we, through index testing, we ultimately are able to find other partners, and if we are able to win in that regard, that can also assist us with issues around partner disclosure and pediatric disclosure. We also felt that the stigma needs to be addressed. It was quite a relief to see that during the survey there were a number of people that were willing to participate, and we also discussed around how some of the participants in the survey could have been affected by the issues of not wanting to disclose, and how that can potentially affect what we might see in the long run as well. and looking at some of the participants as well that were not willing to have bloods collected. And we also wondered with regards to the young group, how many of them could have been children that were not disclosed to, that are now being classified as living with HIV and not knowing their status. So we thought through various engagements, we should be able to remind everyone about how common HIV is, so that if the stigma is minimized, therefore our ongoing surveys as well might be more fruitful with more participations from the communities. With the issue of role models, we thought that it would be important for us to map out which groups of children are more influenced by which specific figures. So looking at the family clusters, nuclear versus extended families, those that are at school, out of school, and also in relation to the hobbies and also their own personal interests. We should be able to identify specific role model figures that might be able to engage them. The challenges, however, would also lie on how much emphasis we are putting on role models. As some of the colleagues have mentioned, if the role models are slipping up, and some of the implications around that might also be negative. So we also explored on how we can look at community-based figures that sometimes can provide good role modeling, even through some behavior that might not always be considered positive. And there are also role models that are positive off the bat. But those are just some of the things that we just wanted to drop. And then the last part with U equals U, in wrapping up, we do understand that implementation, as the other group has reported, has not been fully started, as we know that there were several engagements and discussions around how well the phrasing will be done for U equals U, to avoid the confusion around mother-to-child transmission and mothers having a suppressed viral load, as opposed to the study that was focusing on sexual partners. So those are some of the things that we are hoping that we can move past, and the trainings that have been planned for can then kick off. This is Group 2. I thank you.
No, thank you very much, Group 2. Let's move to the next table, which is that table. Table number 9, am I right?
Yes.
Please.
Good afternoon, colleagues. My name is Philip Gwinda from Right to Care. I'm a district coordinator for VMMC program. I will be presenting question 1 under Group 9. So the question was, what are the lessons learned in the province? Us as Group 9, before we going to the sub-questions, we asked ourselves some questions, especially concerning the sexual activities, especially among young girls and boys. So the question was, what's happening in terms of sexual activities, especially here in MPUMALANGA, in rural areas, because that's where we can see that there's a lot of sexual activities. So in that questionnaire, then we ask ourselves, are there no any activities that are being implemented in the rural areas, which are only done in urban? The other one was, are there no youth initiatives that are being implemented in rural areas? So the other one, any form of communication to talk to those young boys and girls at the rural areas. So the key lessons identified by the group was the poor regulation of the entertainment areas, especially where the young boys and girls go, there's a poor regulation. Sometimes they end up drinking and getting involved in substance abuse until late. So that's where it leads to engagement of unprotected sex. So the other point was family structure, which are child-headed families. So usually in the poor child-headed families, usually because of lack of income, so usually a girl child, they end up falling on early sexual engagement so that they can support the other family members. So the other point was termination of pregnancy is very high in some districts. So the young girls use this termination of pregnancy as a measure, so which lead to low condom use, and again the HIV infection increases. So the other point was the influx of immigrant workers, especially in our mining towns. So usually when the shaft closes, they shift to another town. And when they arrive, because when they arrive there, the local girls, especially the local girls, they saw them as their blessers. So they end up being having multiple partners. Then there will be a high transmission of HIV. So the other point, especially the engagement, the involvement of the parent and the SGB, especially in the curriculum, other groups already mentioned. So other thing is educating, especially the grandparent, especially about HIV, even disclosing the HIV status to the young ones at the early age. So the other point was the as a department, we must have a policy for sexual, especially comprehensive sexual education at schools, especially where there will be peer-to-peer engagement, especially in the peer-led dialogue. And the other point is training the SGBs and the parents about the CSE program. So the first sub-question, the implication of shifting epidemic. So when the HIV prevalence is shifting, so usually there is a surge of a non-communicable disease. So usually when the HIV is shifting to the right, especially to older people, so there's high chances for them to contract, to have another non-communicable disease like hypertension and diabetes. So the other one is encouraging a healthy lifestyle for those people who are already on treatment. Treatment fatigue got an impact, especially to people who are living with HIV, especially when there's an additional non-communicable diseases. So when someone is shifting from taking one tablet to take another tablet, so it becomes a burden to that person. So the other thing is encourage a continued adherence of treatment to avoid defaulting. So meaning it's via adherence clubs, so that they can encourage those people who are already in treatment to continue taking their own treatment. So the other point, it was long-term side effects from the medication. That was already mentioned by other groups. The source of information about HIV is a comprehensive stakeholder campaigns. Distribution of pamphlets and condoms, especially on the social areas, especially can be on the taverns. The other one is zikhala kanjani. It's as it could work. Try to buy in more youth who can to get involved to know more information about HIV. The last question was, have prevention strategies for men been successful? The answer was yes. It was via men championing change, VMMC, men's dialogue with the traditional leaders, involvement of civil society, comprehensive men health, especially when in time of traditional and male medical circumcision. Thank you.
Thank you very much. We are moving to table number 8, and we will finish with table 7. Table 8. Okay, let's move to table 7. Table 8, they are not ready. Table 7, can you take us through? Is there a challenge with table 8? Or the rapporteur has gone out?
Table 8, ofuni mic. Okay,
No. Sorry, Mr. Mbula, I've given them a mic. I just want to establish. Table 8. Do you have a challenge with the reporting? Oh, okay. Okay. Let's take group. Table 7, we will finish with table 8 as they're still sorting out themselves.
Ngiyabonga, ngiyanibingelela emini nasekuseni. Yeah, my name is Umvula Kamnisi. I'm coming from civil society. I'm the second deputy chairperson with civil society in the province. I represent the 18 sectors that are focusing on making sure that by 2030, then we have got an HIV/AIDS free generation. Hence, then our programs are run from Goma sub-district, Ayogoma district, Besachina. As a province, we are coordinating whatever is happening on the ground in Gabon. And represent group number 7. Yeah, our question was, or is, question number 3, what needs further strengthening in the province or the district program? That is the main theme. The second one says, what has been the results of the voluntary medical male circumcision, in brackets, VMMC program? The third one, have youth HIV prevention campaigns being successful at reaching its targeted audiences? The last one, have HIV prevention strategies for men being successful? What are the best practices to focus on? Thank you so much. Then I'll be responding to the 4 questions cross-cuttingly.
Sorry, then, how many questions?
4. There are 4 questions, but the main theme, the main question is what needs further strengthening in the province or the district program. That's the overarching question.
And created a group 7. Because it doesn't actually feature there. No, I'm being honest. Nanti created continue, but it is not among the questions that you were given. So you were not compliant to.
Then ngizocela ukuthi i-group protect ngoba this we've been discussing.
Go ahead. I thought maybe if you put it as a preamble, but don't put 4 questions when there are 3 questions. Thank you.
Okay, thank you. Ngiyabonga bamkosi bengisemoyeni. Remember ngumfundisi. Hallelujah. Yeah, umbuzo othi what could be strengthened further? Sihlezi as a group sibonile ukuthi we need to strengthen our relationship with the House of Traditional Leaders and Khoisans. The reason why we are saying that, because Amakosi, or the traditional leaders, are the custodian of culture, and also they have the influence in their respective villages, where they are respected, they are listened to. Having to work with them, then I think it will be good for them to be able to make sure that the human rights issues are addressed in their respective villages or places. Then now, Sapina Sakobega 40 Sati, we need also to strengthen in the Bayani a survey, because we have noticed that a survey and the methodology that has been used, it has a low intake in terms of Abantwana between the age 0 to 14. Hence then we are saying we need also to involve the local institution, the local stakeholders, like also parents and the communities. Also to use and also support the local universities. Like for instance in MPUMALANGA, we've got a new university. They can also engage and also help to empower our local university in terms of the survey and going forth. Then now we are also saying we need to also strengthen, making sure that also involve abazali, nabantwana during the weekends or the school holidays. Because now, akusilulo access abantwana during the day, because basa skolweni, kanti futhi nendaba yama consent form, ama consent is also an issue. We're saying let's involve abazali and also the communities. Then further than that, we said the awareness on PrEP, I think it is key, on create awareness on PrEP, that has been said also, and also the issue of uptake. But we also acknowledge that the issue of HIV is not a biomedical issue, also the issue of poverty, unemployment, and also inequality, one of the drivers of HIV, also need to be addressed holistically. We talk about the issue of VMMC result. Yes, we have successes in some districts and also some gaps. We're saying where there are successes, then we need to share those successes also and lesson learned. And where there are gaps and weaknesses in some of the district, then we need also to empower and strengthen, making sure that men also, attend and participate towards making 2030 an HIV/AIDS-free generation. But we also acknowledge that we also encourage, men also encourage women to use the female condom. Because remember, it takes two to tango. This is partnership. Then we use our condom, also the female also to use their own condoms. I don't see the The reason why you are saying that, I remember while I was training Amakosi last week, 5 and 6 at KZN or Oku district. Abo mama bati bona abo wasebenzisa ama-female condom. Ngoba bathi abanye bayawasaba yathusa. Abanye bathi abakwazi ukuwasebenzisa. That's one of the gaps that we've identified with the women. We need just to empower them to make sure where are the challenges with the female condom. Because the reason why we are afraid about the issue of substance abuse as one of the drivers. Because uma ubaba afikile asaziphuzela into zakhe, kwesikhathi condom alisetshenziswa correctly. Ngoba kwesikhathi izinto suke sezivukile ubaba safuna into zakhe angasalisebenzisi kahle. But if umama asebenzise a female condom, it becomes also a prevention method. Ngamagama, it takes two to tango. Siyandlula bazalwane. Then kuma youth program, we also acknowledge ukuthi yes, akhona ama program akhona implement while different NPOs nama development partners, but we also say we need also to strengthen what is the AMA program adolescent girl and young women in terms of advocacy and making sure ukuthi abantwana bayavikeleka, especially the youth, the girl and the boy child, in terms of the Boys Championing Change program. Men HIV, okay, we also said that in the Abiyama traditional leaders, we say that, but ngoba okuningi sebakuthethe bamkosi angifuni ukuphinda ngoba ke ngizobe ngirepeata kanti sesimene ukuthi siyena silunchini abaye mhlawumbe sebalambile amathumba ya complainer, then ngizohlala phansi ngiyabonga.
We can do better. We can do better. Let's give the last group. Thank you very much. The last group is group or table 8. Yeah.
Good afternoon, colleagues. I am Innocentia Lusenga, clinical. I am Innocentia Lusenga, clinical mentor from Nakosa, doing GPV response Anankangala. I will be representing group number 8. So say the only thing that we're gonna say, we're just gonna add off what has left behind, because it's a reputation, not shying a corner, just putting it the way it is. So we were doing question number 4 there, and on what we're adding on top of the changings and successes, we're talking about messaging and branding of our cars, our t-shirts, our whatever that we need to brand to show how we can bring, or how can we bring these young girls, these young women to our services. Remember, we need to go to their platforms. As for me, HEYW, but an adult HEYW, right? So they need us to be on their level so that they can come to our services. But with the challenges of that branding and messaging that we have considered as a group, we are not having a feedback or an evaluation tool to say, when we are branding these cars, our t-shirts, your WhatsApp, your whatsoever, does the message goes straight to them? So that's a challenge. Yes, we are sending messages, but we don't have a proper tool to say, this is what is being transpired. And then another thing, just to add on top of the counselors, they've said it, the other group, but we need to, again, to people that are close to them. I can't just go from clarinet and go and talk about clarinet or talk about community there, where else they don't know, even me, who am I? But we need their counselors, we need their chiefs, their people that are trusted, that are being seen every day by them. So another thing that we have spoke about, in terms of, I think it was the last question, how is HIV testing and status awareness, art and viral suppression seen in your community? In that one, we spoke about stigma, to say stigma is still there and it is working properly. And we still have a long way to deal about stigma. Can I start to the next patient that is next to me before I tell you? So let's try to deal with stigmatization. And may we please have a funding from the department, NGOs, when it comes to HIV programs, because they are not funded that much. So may we please have money so we can continue render the services. Thank you.
No, thank you very much. Short and sweet, straight to the point. Colleagues, let's give a very big round of applause to all the 10 teams. Yes, in the interest of time, I think we are moving, and I'm going to introduce myself. Colleagues, looking at the agenda, as a province, we need to give a reflection on what has been presented by HSRC. And I'm actually going to start, then it's going to be my colleague from the Department of Health representing Chief Director Primary Health Care, Dr. Cheryl Nelson, who could not make it. I think first and foremost, let's congratulate HSRC for the milestone since they started up to the 6th SABSSM survey that they have actually conducted. It is indeed assisting us as a province in terms of programming. The granular data that has been provided will assist us to program our interventions. More so, we will then be focusing on the areas that were shown as to be areas that are still a challenge in the province in terms of HIV. The request that I'm actually having to PEPFAR the rubber hits the road at a local level. If we remain at a district level due to funding, I just want to request PEPFAR to consider actually putting more money, because what we are seeing from this exercise is actually giving us a clearer picture. It would even be better to understand at a local level to say, how is the picture at a local level? Look, the previous NSP was talking about focus for impact, which was saying to us, let's go to a ward level to understand the dynamics and the determinants of HIV at that level, so that we no longer take the posture of saying there is supposed to be equitable distribution of resources, but we are then able to respond according to the needs on the ground in terms of what is it that we are learning with regard to the situation on the ground. And it is within that context that I'm humbly requesting, but I know CDC as an implementing agent of PEPFAR is also here, and please continue when we do the next one, if they could actually increase the funding so that we actually go lower than the district. You see, the other thing that is actually very worrisome, even though one was actually able to pick it as they were presenting, when they talk about new infection at the national level, it doesn't assist us that much if the national level, new infection is actually aggregated at the national level. We would want to understand which are the wards, which are the sub-districts that are contributing, for us to look at this picture of Nkangala, this picture of Hersbande, this picture of Ehlanzeni, which are the locals that are actually dragging us down, so that we understand, we put more attention, we put more focus and more support actually to deal with those areas that seem to be dragging us down on average in terms of the performance as a province. And I think it's about time that we need to begin to invest in prevention. Look, colleagues, I think even the attitude and the posture of funders is for us to say, let's go out there, find them that are positive, put them on treatment. But those that we find to be negative, there's very minimal investment that we are doing to keep them negative. And I think it is about time so that there is a lot of investment in prevention. If we focus more on treatment care and support, which is also costly, the UNAIDS, former director Peter Payot once said, the cost of inactivity is far greater than the cost of activity. So in other words, if we were to invest a lot of money to do something to prevent, we would then actually be planning to save less as we actually move forward. The issue of the numbers that were presented by Prof. Zuma are really encouraging, but at the same time depressing. I'm saying this because part of what we saw is that as a province, the numbers of people that are actually living with HIV have grown up to 890,000. But however, so we still have a shortfall of 130,000 people that we still need to put on treatment, which is actually a very serious cause for concern. us moving out here, we need to be finding those people who know their HIV status, but who are not on treatment, and make sure that we actually put them on treatment. Secondly, I want to appeal to the officials from the Department of Health to say, we understand there is a position from the National Department of Health when it comes to you is equals to you campaign. But the posture of this province, till to date, and colleagues have actually said a lot about that, the you is equals to you in MPUMALANGA has not been launched because there is actually a reluctance from the Department of Health in terms of them actually leading the process. Colleagues, we are one province that believes that when partners come into the province, they are not coming to lead, but to support government. We are very clear. But if government is actually failing to lead, then you are even demotivating and demoralizing those partners who are actually going all out to mobilize resources to come and support the province. So it is within that context that we will actually take this matter up so that we launch the U is equals to you and move beyond to scale it up, because evidence has shown beyond any reasonable doubt that if people are to be actually put on ARVs and they are virally suppressed, chances of infecting other people are minimal. And it is within that conviction that we want to actually comply with that, because this information was actually not just given to us for cosmetic purposes, but for us to implement and see the difference that is actually happening in MPUMALANGA. It is also worrisome, colleagues, that throughout all the indicators that were actually projected, performance in rural areas remains a challenge. And I'm not so sure, Prof, if rural areas was actually inclusive of the farming community. And I can tell you, when you look at the two districts that we are having, almost all three of them, they are all rural districts because they are all former homelands. When you go to Ehlanzeni, is the former Gangwane and the former Libua. You go to Sibande, is actually the former Gangwane government. I mean, former Gangwane government. You come this side in Kangala, you've got the former Kwandebele. So it then tells us we are dealing with a very rural province. And it is within that context that our intervention should actually be biased. And we are not going to be biased because we want to be biased, but the data is actually directing us to be biased towards these communities that are actually, that seem to be, affected in the sense that our services are not actually reaching them that much. As much as we talk about men and women, I think Dr. Matoro in his presentation, he spoke about the issue of disclosure, pediatric disclosure. As a province, I can, with confidence, say to this House, we are seeing a drop in the number of children below 15 years who were on ART, who are no longer on ART. And some of the reason could be that these kids, because whoever that was taking care of them, who tested these kids, they were taking treatment, but now they are grown up, they want to understand, why am I still taking this treatment and nobody has ever disclosed, and they decide not to take this treatment any longer. These are some of the challenges that we are actually facing as a province that we will have to actually try and actually address them head on. Colleagues, the other thing that came from this presentation was that the perception that men do not want to test, it's a fallacy. Men are testing. I think our only mistake that we are making is actually us expecting men to come to our public health facilities. And I think it has actually been echoed several times to say it's about time that we actually take services to men than expecting men actually to come to our public health services. Because one speaker did mention that our public health facilities are not men-friendly. Our healthcare system are not men-friendly. Even if you actually dig down in the mine, as you've said, through the rope and say there's a tavern, as long as that tavern is actually men-friendly, men will come in numbers. I think we still have to actually increase the uptake in VMMC. Scientific evidence has actually shown that VMC is actually a preventative strategy. And we need to encourage men seated here, and I'm excited that we've got also the civil society seated here, especially the EXCO of the province, to say let's activate the men's sector. And tomorrow I'm going down to Gomakegeza, where the House of Traditional Leaders is actually having a dialogue with men on HIV, including gender-based violence. And these are the kind of engagement and discussions that we definitely have to actually take on. I think let me also appeal to funders. What we've also picked up, as this group did mention, that on a quarterly basis, as a coordinating structure, we are coming together to look at the performance of all role players in the province, irrespective of who funds them. But the complaint and the message that we are hearing loud and clear from implementing partners is that funders are actually running after numbers, and numbers are not assisting us. What came out today is that we are looking for the yield in the cascade, HIV cascade, not the numbers. If you are coming in the next performance review meeting, Bonga, you tell us you've reached so many. The next question will be, how many out of those that have tested positive have been linked or have been initiated? Because it's not a question of just testing, but we want to make sure that every single person that tests positive is linked and is initiated. The number has actually been given to us through the study, and those are actually the things that we have learned. And lastly, I think the COVID-19 pandemic has also taught us a lot of lessons. And it is within that context that when you recall the regress that we had because of the hard lockdowns and regulation and stuff like that, there are lessons learned. Today we're talking of COVID-19 that seem to be actually also, emerging again. We're talking of mpox. So whatever that we are actually doing, we need to come up with strategies that whatever pandemic that faces us, we should actually be in a manner that we are compliant to Goal 3, that talks about a system that is well-oiled and well-prepared to respond to any form of any pandemic, such that programs like HIV, TB, and STI, even in the presence of any form of a pandemic, will never actually suffer. I want to take this opportunity to once again thank you very much, colleagues, for the work done. And before I allow my colleague to come, there is a car with a registration, JHH 703 MP. Please, they are requesting that you move your car to a parking bay. It looks like it's blocking traffic. JHH 703 MP. Even if you don't stand up now, but please, you can pretend to be answering a phone while you move to remove your car. Thank you very much. Let me call upon my colleague from the Department of Health to come and give her remarks. Thank you very much.
Good afternoon, everyone. I'm Janice Paulson. I'm the Director for Strategic Planning at the MPUMALANGA Department of Health. So I wasn't expecting to be giving a reflection on the, on the session today, but anyway, here I am. So I think a lot has been said already. We had a fantastic presentation on the results of the survey. And we've had robust conversation, discussion in the different groups with a lot of feedback, including a reflection from my colleague, Mr. Nkosi. So I won't repeat everything that has been, I won't repeat anything. But I just want to start by saying that I walked into this room this morning and I looked at that poster over there, the one with the heading HIV/AIDS in South Africa. And I saw that the first HIV case was in 1981. And I mean, it was only then that I realized that we've had 43 years of HIV in South Africa, so it's nearly half a century. And I think our country has been through quite a lot in those 43 years, but we've also made great strides in addressing it. We've got a very successful ARV program. It's the largest in the world, and as a result of that program, South Africans are living longer. As we can see, our life expectancy has been increasing. But we must also acknowledge the burden it places on our health system as one arm of the quadruple burden of diseases. So some of the findings from this survey is that we're seeing a shift in our epidemic. So our epidemic is stabilizing. ART coverage has increased and viral load suppression has increased. But we still have disparities in the burden of HIV between, HIV prevalence between males and females. As far as our 95 targets go, we're sitting at 87.3, 94.5, and 94. So the last two we're doing well, but as was mentioned, this is completely reliant on that first 95, which is the number of people who are living with HIV who know their status. We also have disparities between the districts in the 95 outcomes. And also younger people have the lowest first 95. So there's still a lot of work that needs to be done, and I think it's our colleague at the back there, Mr. Chabalala from Broadreach, who said, if we are going to reach our targets, our 2030 target, we're gonna have to start thinking outside of the box, because the low-hanging fruits are no longer available to us. It's gonna take a lot more work to reach the people that are almost lost to the services. We don't know where they are. And so we've got a big task ahead of us. So then also some of the findings, what was news to me is that so our incidence levels are dropping, and that's great news, but it also means that we aren't able to determine the incidence at the local level, which has already been stated, it's not great. It's not great for planning, and it's especially not great for me, because I always get asked by the Office of the Premier all these things about HIV. Including incidents, and I mean, the information is often not available, apart from some of the models that are in existence. Another thing that was mentioned was the participation rate needs to be increased. So clearly there are barriers to participation, and we need to think about what our role is as the department in increasing this. We've seen that our prevalence has decreased, but we still have 30,000 more people living in MPUMALANGA that more people compared to 2017. And 100,000 people living with HIV who are not on treatment. And I think for these things, it's going to take a whole of government and a whole of society approach for us to address these things. We need to address siloism, which has been mentioned several times. Not only there's siloism between the various departments in our province, but also between the departments and then the NGOs. So we need to figure out ways that we can work better, not duplicate processes, streamline things, and yeah, so we can so that we can move forward in trying to reach our targets for 2030. So there's a target for 2030, which is to end the HIV/AIDS epidemic as a public health threat. And for these, we need to revisit the programs that we know have worked and which may have fallen away. We need to keep our good practices. And we also need to work on identifying gaps in testing and treatment and in closing those gaps. So I think that's all from me. I just want to say, once again, congratulations to the HSRC for the outcomes of the survey. Thank you to them for all the work that went into administering the survey, conducting the survey, the analysis. It's a lot of work. And then also in the dissemination. This session is really appreciated. And then also to all our supporting partners who are here today for support and guidance. And I think it's definitely something we need to continue to work together so that we can actually achieve our goal of in 2030 ending the HIV/AIDS epidemic, which is only 6 years away. So we don't have a lot of time. Thank you.
Thank you so much for all the speakers for the rich reflections and also the representatives from the tables. Just a request for the HSRC colleagues to ensure that attendance registers are signed in each tables, and then they also hand them over to the logistics team outside. We are now moving to the evaluation. We mentioned in the morning that we hope that this is the beginning of many engagements that we will have, provided we have funding, of course, and would like to see or get reflections in terms of what has worked and what needs to be improved. So we will allow you about 10 minutes. 10 minutes is a lot, and I'm continuously standing between you going to the restaurant. So about 5 minutes to scan. The HSRC facilitator will assist you there to scan and then respond to the few questions that are there, just to help have an understanding. Of course, some of you that are not able to complete it now, you can also complete it during lunch. We won't close the link until later on. So please, we would really appreciate your engagement, and we hope it won't be 16 people as it was in the morning. As you do that, I'm going to also ask Dr. MPUMALANGA Zungu to also come forth. She's one of our principal investigators for SABSSM. She's also a strategic lead in our unit. And I don't know how I can ask her my boss' name today like that, but please, a warm welcome to her. Thanks.
Thank you so much, Lelo. You are lucky that is not a performance appraisal season. No, I'm just joking. Good afternoon, everybody. It is afternoon. We've been here since morning. I'm here to really give a vote of thanks. And like the previous speaker, I didn't know that I was going to be asked to speak. The boss there, who is Lelo, asked me to speak when I came in. So really it is an honor for us as the HSRC to have such a full room of everyone who has taken time away from what they are doing and came to be with us for the whole day, really. 2 o'clock, it's the end of the day. So I just want to start by thanking everyone in this room. Can you clap hands for yourselves? You've remained engaged. I haven't seen a lot of people outside. Those that I've seen, I could see that they're really in a meeting, and it says a lot when people have other engagements, but they're willing to come and sit here and go out for another meeting. I wish to thank I have a list from Lelo, but I will also add a few things from myself. I want to thank the HSRC team. Maybe if they're around the room, just stand up so that they can see you, for all the hard work. This study is not easy to implement. It takes long hours, weekends. So I want to say thank you to everyone. And as they're doing these dialogues, it's also taking a lot because they are moving from province to province and they're supposed to provide the data. So colleagues, thank you, and also thank your families for making you available. I also want to thank CDC. As you heard, we've been together with CDC since 2002. It's a long road. Not many funders are there for the long haul. But CDC has been with us for the long haul. Some of you might not know that when we started, probably we had about, 4 or 5 different funders. Everybody wanted to put a little bit and a little bit. And the key thing about this study is that it is run by South Africans, for South Africans. So it has been a capacity building platform, and you saw some of the young people come and present the study results. So for us, that is a plus, that we've been able to not only grow within the study, but also provide capacity. So some of the young people you see here are doing their masters, their PhD, using this information. And I think my boss forgot to market the fact that you can download, not this one, 2017 going backwards, can download, do your PhD on it, your master's, MSc, and so on. It's available, even papers, if you're someone that can do that. So CDC, I want to thank you. You have been really a partner for this work. You've trusted the HSRC with this work when it was not easy. We come from the days of denial and so on, and also just questioning if the study is sitting in the right place. But the CDC has stood with us, and we've been together. One of our program directors, Mr. Nkosi, you said something very important about the need for additional funding so that we can go deeper and deeper. But I want to also challenge the provinces. Please also, when you are doing your budgeting, remember that in 4 years' time, these people will be repeating this study. Or 3 years' time, I'm not sure now. When we do that, it can even be in kind, things like HIV testing, because it makes you a partner in the study, not only a recipient of the data, but you are also able to direct what is it that is important for you. So when we are planning, please also remember the study. We thank CDC for having done what they've been able to do. But for us to dig deeper, we need to work together with government. We also want to see government owning this study. It's very important for us. Thank you to all the speakers that came prepared. It's been very interesting. Everyone on the tables, I really enjoyed the inputs from the different groups that have been sitting, giving feedback. So now I'm going to go to the list that has been given to me by my boss to make sure that I do the right thing. Number 1, the Office of the Premier. we want to say thank you, thank you, thank you. And the team that works with the Premier, we want to thank you. Stakeholders, civil society, everyone who's been here, working with the team to put this together, our development partners, representatives of various government departments who are so happy to be sitting with health and education and Department of, you know, everybody's there in the table number 4. That's when I give them a shout out. But yeah, I'm sure the other tables also had representative from different sectors. Head of secretariats, thank you so much. And this is not the end. I think we do this, but I think this is the first time that we've had an opportunity to really, really come back and share our results. So again, I want to thank CDC, because most funders just fund us to do the work, not the feedback that has happened. So I want to say thank you. And we hope that the data will be used for what it's supposed to, which is to help you with planning, programming, being able to target. And I think I was so excited when I was listening to people talking about young women, others were talking about PrEP, you know. So you're already identifying the gaps, and that's what the data is supposed to do. So we hope that what we've provided contributes towards us reaching that 2030 that everybody has been talking about. Yes, maybe the indicators do not show us that we are on the right track, but I think there are good things that are happening. Incidents that is showing a decline. Some of the behaviors, I thought when I looked at the 2017 and 2022, we're already seeing the difference. So it means there are things that we are doing right, and we need to do more of them. With those few words, I hope that you will enjoy your lunch and also travel safely as you go back home. Thank you so much for your time.
Thank you so much, Dr. Zungu. Colleagues, just the last 5 minutes to complete the evaluation form. While you do that, note that the restaurant is on your left, close to where you had your tea and sandwiches in the morning. And colleagues that, there are colleagues that need to see Nomfanelo to finalize issues around traveling back home. So she's waiting for you outside. And again, just to thank everyone, especially Mr. Nkosi, who has really driven the program today with me. We really appreciate it and hope to see you soon. Thank you so much and travel safe.